हाँ वो कर दिए 10 सेकंड लाइव हो गया. Assalamu alaikum. I welcome you all in Get Pharma Webit Learning Cell. As we all know that Ramadan is approaching and this is the best opportunity to refresh our knowledge base for the management of diabetes in Ramadan. So for today's discussion, we have an expert with us who has 21 years of clinical experience and he is currently associated with Buckeye Medical University as a professor of medicine. I welcome Professor Karim Kammeruddin on behalf of Get Pharma and all the audience who are attending this webinar virtually. I will now request Professor Karim Kammeruddin Sahab to conduct the session.
Assalamu alaikum. Thank you very much, Dr. Ahmed, for kind introduction. So right away, we are going to see what we have got in our lot for diabetes and Ramadan this occasion 2020. And under the lockdown, I think this is the way to make that thing forward to you people. Thank you. So we are going to start with the first slide, that Ramadan and type 2 diabetes management. We start with the holy words, "Oh, you believe fasting has been prescribed to you as it has been prescribed to those before you, so that you attain taqwa." So this is the first word that to start this kind of a session, I think it would be nice. We know that Muslims constitute more than 20% of world population. And it's in figure, you can say 1.2 billion individuals that we are talking about. And they are growing faster than the world population. So it's one of the fastly growing religion across the globe. And we can see in this particular slide that these are the areas where they are heavily populated. But this is one part of the story. So if you see this particular slide, you can see that the growing problem of diabetes in Muslim majority countries, you can see in one generation time where we live, it's around 80% individual. In next one generation time, we are going to have more people having diabetes. It is just next to African countries where the projected population to have diabetes would be increasing in terms of more than 100%. So if you talk about these studies, how much the population wants to have fasting, how much the Muslim demand, despite of their current illnesses, the religious ritual of fasting, we can take the help of Creed study. And if you take this particular study, you can see that more than 94% individuals, they fast. And if you see, they fast more than 15 days, and around 67+% individual, they want to fast, and they fast most of the time throughout Ramadan, the whole month of Ramadan. So if you talk in terms of management guidelines, you can see that there are management guidelines, but management guidelines varies, and the strict abidance to management guidelines also varies between different countries. So what are the risks that are there in fasting for a patient who is diabetic? You can take first hypoglycemia, and you can see that hypoglycemia is a real-time risk for diabetic individuals. The second that comes in mind, we all know that we not only fast, but we also feast. So this is actually hyperglycemia as another risk. Third, you can see diabetic ketoacidosis as a risk. And then finally, we all know that Ramadan, if like in this particular occasion, if it is more than 14-15 hours a day, it may lead to dehydration and sometimes complications of dehydration like thrombosis. So if you take International Diabetic Federation diabetes and Ramadan risk category, we can classify our nearly all patients into three major risk groups. The first two groups are very important, and they are the one where we should be particular about giving them the permission to fast. Particularly, a very high risk group include people who are of older age. They may be poorly controlled type 1 diabetic. They in the last 3 months have got recurrent hypoglycemic episodes, or having hyperosmolar state, or having ketoacidosis. They may contain of individuals who are having pregnancy with uncontrolled diabetes previously existing, or maybe a GDM, and they require sulfonylureas and insulin at times. And they also comprise of individuals who got advanced kidney disease like stage 4 or 5 kidney disease that constitute the very high risk group. Similarly, so the high risk group is also there, and that high risk group include patients who are having relatively stable but still up to stage 3 of chronic kidney disease. They also include poorly controlled type 2 diabetics. They also include patients with multiple dose injection of insulin or infusion of insulins, pregnant ladies who are controlled by diet and metformin that it include, and patients who got treatment with drugs that may affect the cognitive functions. So these are the individuals which are taken as very high and high risk. So the first thing that being a manager of diabetic individuals, we should first categorize our patient whom may ask you before Ramzan whether डॉक्टर साहब मैं इस दफा रोजा रख सकता हूँ या नहीं. तो हमें अपने पेशेंट को पहले क्लासिफाई करना है, और अगर हम खुद क्लासिफाई करेंगे तो ही हम उस मरीज को सही गाइड कर सकें. So the guidance for such kind of individuals may include that check your blood sugars, that is put them very hard on this particular point कि SMBG को उसको कराना है, किसी सूरत उसको इस बात पे पाबंद बनाना है. फिर उसे ये समझाना है कि किस पॉइंट्स के ऊपर which we are going to discuss obviously, कि किस पॉइंट उसको ये बताना है कि अगर इस पर्टिकुलर पॉइंट से ऑफ है उसकी शुगर्स कम या ज्यादा तो उसे रोजा तोड़ना है. इस बात के लिए भी उसे पाबंद बनाना है. अदरवाइज ये जो दो ग्रुप अभी हमने डिस्कस किए, कैटेगरी 1 which comprise of very high risk group and category 2 which is high risk group, they are the one who are not as a first go as a knee jerk should be allowed to fast, and they are to be counseled that thing before starting of Ramadan. The third group include a category of individual with low risk, moderate to low risk, and they are the one who are actually well controlled type 2 diabetics with one or more of the following drugs. Like besides lifestyle modification, the patient might be on metformin, necarbose, thiazolidinedione, including pioglitazone, second generation sulfonylurea, incretin-based therapy, SGLT2 inhibitors, or insulin, including basal insulin. So these are the one who should be at least taken as moderate to low risk individual, and they also need a structured education before Ramadan, and they also need to abide with SMBG monitoring. Next, how to manage these individuals. I'm not going to go in depth. Obviously, this does not go into the scope of such kind of webinar alone, single solo lecture, to give you each tips and bits of management. But we are going to touch the outlines, mainly outlines of management. The first and the foremost important thing is a Ramadan focused educational program, and that include number one, the risk quantification of a particular patient. Particularly, the previous slide also gives you how to categorize your patient, the risk. Then monitoring of blood glucose is very important, which we are going to touch. Then food and dietary advices that obviously patient also want and you also keen to give advice. Exercise, because nowadays we are in lockdown. This is something which is not previously seen by most of us. So it also need to be touched. And then the medication adjustment and when to break fast. These are the things that we need to focus upon. If you talk about quantification of risk, यानी रिस्क को अगर देखने की अगर हम बात करें तो हमें नजर आता है कि इसको हम दो हिस्सों में डिवाइड कर सकते हैं. Also include number one, the type of diabetes and the patient characteristic. What are the patient characteristics? Previous Ramadan experience, presence and absence of comorbidities and complication in the patient. Then social circumstances, patient medications. On the other part, if you talk about diabetes, what are the things to consider? Which type of diabetes we are talking about? Are we talking about type 1 or type 2? Or what was the previous and current risk for having hypoglycemia in a particular patient who is on a particular drug? So these are the things to consider. Then if you talk about calories intake in a person during Ramadan, it has got two different variables. First It may vary between 1500 kilocalories a day up to 22 kilocalories a day between men and women, and with provision of either we want to make weight reduction or weight maintenance. And how to distribute these calories within the Ramadan phase, we need to focus that around 50% or 50 to 70% should be focused after Ramadan iftar and snacks between two meals, and only up to 30 to 40% it should be placed in sahri time or suhoor time. If you need to detail how many times a person need to have monitoring, depend upon the category in which the patient is. Whether the person is in a very high risk group or high risk group, the person need to have monitoring at least 6 or at any time where the symptom of hyper or hypoglycemia ensues. But if somebody is in the low category or moderate category, which is category 3, ideally the person should be monitored at pre-dawn, monitoring in morning after 2 hours of dawn, midday, and then 2 hours after iftar. So these are the times that the person need to monitor. And at any time, if again the patient develop features of hypo or hyper or feel unwell, the person need to have monitoring. When to break fast? The first criteria for that is according to blood sugar. If the sugar falls at any time below 70, 3.9 millimoles per liter, and that is the thing that the person on recheck after 1 hour having 70 to 90 milligram per deciliter or 3.9 to 5 millimoles per liter, the person need to break the fasting. Person also, if found to have after suhoor in particular having greater than 300 milligram per deciliter, the person also need to have break of their fasting. Then if the patient have got symptoms of hypoglycemia or hyperglycemia, we all know that hypoglycemia symptoms include symptoms of neuroglycopenia and increased sympathetic activity, while hyperglycemia features include the features that make them characterized as diabetic, like extreme thirst, that include polydipsia or polyphagia or frequent urination, of fatigue, this kind of thing, including also the vomiting, nausea, and abdominal pain. So they need to break in these circumstances the fast. What are the recommendations for hypoglycemia management? We can give following things, that is 15 gram of carbohydrate or its equivalent. That may include 4 ounces of apple or orange juice, or maybe a sweetened soda, or 3 or 4 glucose tablets if it is available. It's sometimes being available, but most of the time in Pakistan it is not that easily available. It may also include 1 tablespoon of sugar or honey. So these are the recommendations for managing acute hypoglycemia. And we also, with the backup data, knows that patients agrees to break fast if they are properly counseled. And you can see in this particular slide that between 55% to 73% between type 2 and type 1 diabetics, they agrees upon breaking the fast if properly counseled and educated for Ramadan. So how to manage patient with the management points? They are seen from guidelines from 2010 onwards, and we can take help of those. Patients who are on diet and exercise control during Ramadan, modifying the time and intensity of physical activity, that after the physical activity is to be taken much more as compared to in the early morning. And adequate fluid intake should also be enhanced during the iftar and to the time of seher. Then patients who are on drugs, first of all, we have to ensure adequate fluid intake, particularly in this particular hot summer season where we found ourselves in Ramadan. Then people who are previously on metformin 500 milligram 3 times daily, we can make modification in term according to this particular guideline that 1000 milligram should be at iftar time and 500 milligram at pre-dawn time. If somebody is on pioglitazone or a carbose or incretin-based therapy, the person need not to have much change in their regime. If person is on sulfonylurea, which is second and third generation sulfonylurea once daily, then those should be given before sunset meals, that is at iftar, and adjust the dose based on glycemic control and risk of hypoglycemia. If the person is on a twice daily sulfonylurea, you can usually have the morning dose at pre-dawn and the dose at sunset will remain usual. If the person is on insulin premixed or intermediate acting insulin, you can manage with adequate fluid intake into following manner, which has also been touched upon following guidelines after 2010. You can take this particular guideline from ADA, and they state that majority of the dose should be given, the major chunk of the insulin dose should be given at iftar time rather than at sehri time. Like, for example, if the total daily dose of insulin is 20 units, 13 units should be given at iftar and 3 units at seher. So the dose total has been reduced. The total dose from 20 unit has been reduced down to 16 units. 20 to 30% of the total dose of insulin is being reduced, and then the measured dose is being given at iftar time rather than at seher time. There has been further updates to the type according to the type of insulin the patient is on. Like, for example, if somebody is on long and short acting insulin, what would be the dosing during Ramadan? What is the guideline? And these guidelines are being taken from practical guidelines, International Diabetic Federation in collaboration with Diabetes and Ramadan, that was updated in 2016. Let's see first the long or intermediate acting basal insulin doses updatation. What they say that if somebody is on NPH, detamir, glargine, or Doglitec once daily, the dose should be reduced to up to around 15 to 20% in total, and it should be taken, if it is only once given, it should be taken at iftar. Then if somebody is on the same insulins twice daily, take the usual morning dose at iftar and 50% reduction of the other dose at seher time. So this is the guideline in 2016. Then if somebody is on a short-acting insulin, normal dose at iftar, omit the lunch dose and reduce up to 50% of dose at seher time. So these are the general guideline for these kind of insulins. If somebody is on a premix insulin, you can have once daily, take the normal dose at iftar. If somebody is having premix insulin twice daily, take the normal dose at iftar and reduce up to 50% of dose at seher time. And if somebody is having thrice time, 3 times dosing of insulin, omit the afternoon dose, adjust the iftar and seher doses, and carry out dose titration every third day. So these are the 3 important points for premix insulin. What are the new groups that have been added since these guidelines? You can see that the guidelines, recent guidelines include incretin-based therapies, which has been touched somewhat in 2010 guideline, but the other group besides the incretin-based therapy is SGLT2 inhibitor group, and these are new groups. They have got a modest efficacy of reducing the HbA1c, but they are, since they are new group and they are being categorized as the group which is pretty found to be safe, but still this is a bit new group, so we need to have some more detail about that. How these SGLT2 inhibitors actually act. They have got a pleiotropic effect. And what the pleiotropic effect? They have got effect on heart. I'm not going to go into details. It has got effect on renal system. It has got effect on vasculature, positive effect, in fact, obviously, beneficial effect. And then finally, it has got effect to reduce weight in reduction of adipose tissue. So with that, what we actually claims, we claims that it has got an efficacious potency even in Ramadan. And what are the tips for them? The tips that if it need to be started at least 1 to 2 weeks prior to Ramadan. Why? Because it is being categorized under the group as one of the diuretics. osmotic type of diuretics. It actually blocks the reabsorption of glucose filtered load. So it has to be in a select population to start, and this particular choice is to take the group prior to Ramadan, so you can have a chance to adjust what the dose, what are the patients in whom you may start. Patient selection is really very important. किन मरीजों में स्टार्ट करना है, वो पेशेंट्स जो कि डायूरेटिक्स पे नहीं है, जिनका किडनी फंक्शन स्टेबल है, उनमें स्टार्ट करना है. जो एंटी हाइपरटेंसिव मेडिकेशंस के साथ हैं, उनको एंटी हाइपरटेंसिव मेडिकेशन की एडजस्टमेंट के साथ स्टार्ट करना है. फॉर एग्जांपल, इफ समबडी इज ऑलरेडी ऑन अ डायूरेटिक and if you want to start SGLT2 inhibitors, you need to reduce either 50% of previous dose of diuretic. If somebody has got a blood pressure above 140 over 80, then you can add SGLT2 inhibitor as such. But if somebody has been on an antihypertensive and their blood pressure is less than 140 over 80, and if you want to add SGLT2 inhibitors, then definitely you need to decrease the dose of antihypertensive medications as well. So you need all these consideration in your selection of patient for choosing individuals who are going to get fasting. So you need to take these points into consideration before Ramadan. During Ramadan, how to follow them? You need at least to advise them during Ramadan to take extra 500 ml of fluid. And they are also being advised to avoid intake of salt, excess salt, coffee or tea during Ramadan, so that will not make them more dehydrated. And finally, if you want to continue SGLT2 inhibitor even after Ramadan, you can see and appraise the experiences and outcome. What are the drugs that are in Asian population as SGLT2 inhibitors available? We got from dapagliflozin, canagliflozin, empagliflozin, Ipra, Luzo, and tofoglyphosine, all across Asia. But out of these, only these two drugs are available in Pakistan. So we are going to be much more concerned about EMPA and dapagliflozin. We all know that EMPA has got a dose range between 10 milligram and 25 milligram. It has got an elimination half-life of 12 hours. And dapagliflozin in term of 5 and 10 milligram with elimination half-life of 13 hours. If you talk about the safety of glyphosate, these could be taken into studies that are there during Ramadan. And one of the latest study I'm going to share, which is published in 2019, concludes that glyphosate group is generally well tolerated. No serious side effect in terms of hypoglycemia being reported during Ramadan. And they have got slight differences in terms of managing their fasting sugar more with EMPA and weight reduction more with dapagliflozin in this particular study. So you can take that kind of a studies to help yourself in getting some confidence in continuation of this group of drug during Ramadan. If you talk in terms of physician recommendation modification in medication protocol, you can take this particular chart that SGLT2 inhibitor should be initiated somewhat prior to Ramadan, since they are associated with diuresis and fluid loss. And with that, I think I thank my audience for patient listening. If you got any question, we can take them at the moment.
So thank you very much for your very valuable lecture. सर हमारे पास एक व्यूअर ने क्वेश्चन किया है कि उनके पेशेंट को डायबिटिक कीटोएसिडोसिस हुआ था, जिसकी वजह से वो पेशेंट हॉस्पिटलाइज भी हुए थे. तो वो मालूम करना चाह रहे हैं कि क्या ऐसे पेशेंट रोजा रख सकते हैं, और अगर वो एम्पाग्लिफ्लोजिन का इस्तेमाल करना चाहें तो वो किस तरह करें?
देखिए, पहली बात तो ये है कि कीटोएसिडोसिस अगर उसको पिछले 3 महीनों में हुआ है, तो ये उन मरीजों में है जो इंसुलिनोपिनिक है, चाहे वो टाइप 2 है या टाइप 1 है. एंड ये वो पेशेंट्स हैं जिनको हम वेरी हाई रिस्क ग्रुप में कैटेगराइज करते हैं. सो इफ यू आर टॉकिंग दैट काइंड ऑफ अ पेशेंट, द फर्स्ट knee-jerk response would be that they should be counseled that they should not be fasting as a first goal. But if they are willing to fast, so what the important thing would be, we have to have a Ramadan focused safe fasting protocols to be detailed prior to Ramadan. And number two, the second component of the question was that whether they can be put on SGLT2 inhibitor. They are not the right candidate for being put on SGLT2 inhibitor because SGLT2 inhibitors also make people more ketotic. So why we should be adding a drug which can lead them more towards ketosis?
थैंक यू वेरी मच सर। सर एक और क्वेश्चन हमारे पास आया कि एक फीमेल पेशेंट को 3 महीने पहले यूटीआई हुआ था, तो क्या वो पेशेंट रोजों के दौरान एम्पाग्लिफ्लोजन यूज कर सकती हैं?
देखिए, अगर यूटीआई अभी नहीं है, करंट नहीं है, और पेशेंट का प्रीवियस रमजान एक्सपीरियंस जो है रिगार्डिंग रोज़ा ठीक है, तो मैं समझता हूँ आई थिंक इसमें हम कह सकते हैं कि हाँ, इन पेशेंट को रोज़ा रखने में तो शायद कोई हार्म नहीं है एट द मोमेंट, डिपेंडिंग अपॉन also कि how much controlled their sugars are and how much in good health the other parameters are। ठीक है, ग्रॉसली इस किस्म के मरीज को यस कहा जाएगा टू हैव फास्टिंग। जहाँ तक SGLT2 इनहिबिटर्स का सवाल है, एक अच्छी दवा है, अच्छा ग्रुप है, प्रोवाइडेड कि करंट यूटीआई ना हो और उनका हाइड्रेशन स्टेटस पेशेंट का अच्छा हो, और अगर वो रमजान से पहले हमारे पास आए तो हम उनको रोज़ों से पहले इस ग्रुप पे डालें और फिर रोज़ों में इसको कंटिन्यू करें।
सर एक ये तीसरा सवाल जो डॉक्टर कम्युनिटी के साथ एक केस डिस्कस किया गया बेसिकली इसमें कोई एक पेशेंट जिसने शाबान के महीने में 3 रोजे रख लिए हैं और उनका HbA1c भी 9% है और इस वक्त, तो क्या ऐसे पेशेंट को रोजा रखने का हम तजवीज़ कर सकते हैं, और अगर कहें तो वो एम्पाग्लिफ्लोजन के साथ ही है अगर वो पेशेंट, तो उसको किस तरह डोज इसकी एडजस्टमेंट करें?
देखिए, पहली बात तो ये कि शाबान के रोजे से आपको अगर कोई अनइवेंटफुल रोजे रहे हैं शाबान के, तो हमें काफ़ी हेल्प मिलती है कि ऐसे पेशेंट को आप कह सकते हैं कि हाँ, रोज़ा तो रखा जा सकता है बिकॉज उसका बहुत ही रिसेंट एक्सपीरियंस है, उसमें अल्लाह का शुक्र है कि उसे कोई इवेंट नहीं है। दूसरी चीज़ जहाँ तक रहेगी HbA1c ऑफ 9, इससे उसको हम कैटेगराइज कर सकते हैं कि इनकी शुगर जो है पिछले 3 महीने में तो कंट्रोल नहीं रही। तो यकीनी तौर पे अगर वो पेशेंट SGLT2 इनहिबिटर बिफोर रमजान स्टार्ट कर चुका है तो आई थिंक दे आर द वन हु शुड कंटिन्यू, एंड उसको हमें फोकस एजुकेशन प्रायर टू रमजान देनी पड़ेगी कि क्या खाना है, कितना खाना है, अपने डोजेस को कैसे ऑल्टर करना है, हाइड्रेट अपने आप को कैसे रखना है, पर्टिकुलरली इफ द पेशेंट इज ऑलरेडी ऑन SGLT2 इनहिबिटर तो एक्स्ट्रा 500 ml हमने उसकी अफ्तार के बाद के फेज में बिफोर सहर उसको ऐड करना है। एंड आई थिंक इस पर्टिकुलर केस में हम कंटिन्यू कर सकते हैं।
थैंक यू वेरी मच सर। एक पेशेंट ये क्वेश्चन है कि एक पेशेंट इफ्तार के बाद जो है उमूमन जो है देखा गया कि शुगर हाई हो जाती है।
जी, मैंने पहले अपनी प्रेजेंटेशन में भी कहा था कि वी नॉट ओनली फास्ट बट वी आल्सो फीस्ट।
जी, तो उसमें क्या एहतियात हम?
ऑब्वियसली उसमें जो हमारा डायबिटीज फोकस्ड एजुकेशन होगा वो हमें उसको बताना पड़ेगा कि कितना खाना है, कौन सी ऐसी चीज़ें हैं जिनसे शुगर फौरी तौर पे बढ़ती हैं, यानी उनके ग्लाइसेमिक इंडेक्स के बारे में उन्हें बताना है, और उसके अलावा उसको किस तरह से डिवाइड करके खाना है ये समझाना है, और उसकी जो दवाएं हैं उसको हमने कौन से डोजेस देने हैं उनके मुतालिक हमने बात करनी है, तो वो स्पेसिफिक पेशेंट की पैरामीटर्स के साथ ही उनको एडवाइस हम कर सकेंगे।
सर एक लास्ट क्वेश्चन के इसमें देखा गया कि पेशेंट जिनकी हाल में कार्डियक स्टेंटिंग हुई है और उनका शुगर कंट्रोल अच्छा है, तो क्या ऐसे पेशेंट को रोजा रखने का हम कह सकते हैं कि?
देखिए, अगर कार्डियक स्टेंटिंग रीसेंट हुई है, लास्ट 3 मंथ में हुई है, तो ये वो पेशेंट्स हैं जो हाई रिस्क इंडिविजुअल्स में कैटेगराइज होंगे, और उसमें अगर HbA1c कंट्रोल है तो रोज़ा रखना के बारे में अकेले फिजिशियन को ये फैसला करने का मेरे ख्याल में हक हासिल नहीं है, इसमें कार्डियोलॉजिस्ट की ओपिनियन को भी और उसके उन तमाम पैरामीटर्स को जो उसकी जनरल हेल्थ को इंडिकेट करते हैं, इंक्लूडिंग किडनी फंक्शन एंड the risk for hypoglycemia, because well controlled people are more prone for hypoglycemia, so उनकी ड्रग्स की पूरी इवेलुएशन और उनकी डोज ऑल्ट्रेशन, उन तमाम चीज़ों की मौजूदगी में और पेशेंट की बिल है कि वो फास्ट करे, तो हम इसे जो है बहुत गाइडेड ओपिनियन के साथ यस कहेंगे कि हाँ रख सकते हैं, प्रोवाइडेड कि वो हमारी बात को किस हद तक फॉलो कर सकें, और जहाँ उन्हें रोज़ा ब्रेक करने की नीड है, अगर उस बात को वो एग्री करते हैं कि वो ब्रेक करेंगे तो उन्हें अच्छी तरह एजुकेट करने के बाद शायद परमिशन दी जा सके कि हम रखें रोज़ा।
सर जैसे आपने बताया कि हाई रिस्क पेशेंट है तो ये एम्पाग्लिफ्लोजन और SGLT2 इनहिबिटर कम है तो ये सबसे ज्यादा।
जी बिल्कुल, क्योंकि कार्डियक रिस्क पेशेंट जो है ये वो पेशेंट्स होते हैं जिनमें SGLT2 इनहिबिटर्स जो है ये एज ए फर्स्ट लाइन ड्रग रिकमेंडेड है, इवन प्रायर टू मेटफॉर्मिन, अगर आप रीसेंट गाइडलाइंस को फॉलो करें. So they would be definitely managed better with SGLT2 inhibitors, provided इनके nephrological criteria or other parameters be acceptable. Again, this group has got a role to play in such high-risk cardiac individuals.
Thank you very much for your time. Thank you very much for your valuable comments regarding Ramadan and SGLT2 inhibitor use.
Thank you overall हमारी audience का और आप लोगों का केस को आपने make sure किया.
Thank you.
Thank you. Assalamu alaikum.